in the same location as the infarct seen on the proton density. Now, the problem when interpreting diffusion-weighted images is to find whether the high signal is related to true restriction of diffusion in an acute infarct, or if it's just T2 shine through. And you do this by an apparent diffusion coefficient map, or ABC map, which by mathematical methods removes the T2 effects from the data set. So if there's truly, you should have a reduced apparent diffusion coefficient, which you see an elevated coefficient, which you see here in the blue pixels. Okay, so an ACA infarction, it's a less common infarction. There are a couple of things you should regarding the etiology. Primarily embolus, vasospasm from hemorrhage most commonly. Mass effect with subfalcine hernia result in ACA infarctions. So just to recapitulate diffusion-weighted imaging, an acute infarct should have restricted diffusion. This should signal on the diffusion-weighted images and reduced ABC values. Restricted diffusion up to 1 to 2 weeks, at which point the diffusion may normalize compared to brain parenchyma. So you need to also to correlate with the time of symptom onset. So ACA infarct. Okay, next case is immunocompromised adult with altered mental states. And again, we have 2 proton density weighted images through the temporal. You see a subtly elevated signal in the medial temporal lobes bilaterally, and this extends up into the subinsular cortex, again bilaterally and quite symmetric. There's no foci of low signal, which might suggest petechial hemorrhage. And this front coronal FSE image confirms the temporal and subinsular involvement, and also shows quite nicely the inferior frontal lobe involvement. So there's quite a limited differential diagnosis for this kind of picture. And the primary in all these cases, particularly in the setting of immunocompromise, is an HSV1 encephalitis virus type 1. This is typically bilaterally symmetric, and if you see punctate foci of hemorrhage, that is also very characteristic for encephalitis. However, human herpes virus 6 can also give an adentis, the same kind of population subgroup. A limbic encephalitis, which is apparently frequently seen with breast cancer, can have a very similar appearances and is not classically associated with either enhancement or hemorrhage. If you see something unilateral, consider things like a transverse sinus infarction or a labe cortical vein thrombosis, or rarely gliomatous cerebri have been reported to give a similar appearance, again in a unilateral distribution. So you see this symmetric medial temporal lobe involvement, or HSV1, and limbic encephalitis. And this was an example of an HSV1 encephalitis without the petechial hemorrhage, but nevertheless confirmed by PCR. For our next case is a 20-year-old woman who initially presented with a day or two of head shot into the ER, had reduced level of consciousness. So she went to have a non-contrast CT brain. The brain parenchyma looks pretty good. Her sulci look a little bit tight when she started here. I just draw your attention to the fact that the straight sinus and superior sagittal sinus are hyperdense on this non-contrast CT, so highly concerning for dural vein thrombosis. So she went to MR for confirmation of this, and you can see on the non-contrast T1, there's elevated signal, the same superior sagittal sinus and a little bit of the straight sinus here. Now on the T slightly higher level, you can see there's reduced signal in T2. A lot of people do weighted image to look for a flow void or not, and you can get mistaken because blood at various ages can appear to images, so you may mistake it for a flow void. In this case, with the elevated signal on T1 and the dark signal on T2 could either be deoxyhemoglobin or intracellular. And this, the MRV confirms the absence of the superior absence of the straight sinus, confirming the diagnosis of a dural sinus thrombosis. So again, just to recapitulate again, the flow mimics on anatomic MR imaging, globin will be dark on T2, so if you may mistake it for a flow void. Chronic thrombus can little vessels growing into the side, so may enhance. So don't be put off if you see something within the thrombus. And also when you use a time of flight MRV, both methemoglobin are bright on time of flight. So so you can mistake those for patent sinus. In contrast, MRV can differentiate between flow and no flow, however, with probably a better form of MRV to use rather than time of flight. Probably the two best features to determine whether a sinus is patent or not, to look for the flow void and to look for pulsation artifact going across confirms that there is patent flow within that sinus. The things that I find most useful are to look for the hyperdensity and non-contrast CT, to look for while I've been saying that the T2 signal may be dark and mimicking a flow void, carefully you may find that it's not truly black, but there is some heterogeneous signal sinus indicating that it's actually soft tissue material rather than flow. And obviously look at venous infarction, such as parasitical edema, hemorrhage, sometimes left to meningeal enhancement and hydrocephalus as well related to hemostasis. So in this case, is a 5-year-old who presented with poor vision. And both of these are enhanced T1 weighted images in the supracella. You can see a large, relatively homogeneously enhancing lesion that has a kind of a shape which is reminiscent of the optic chiasm and post-chiasmatic optic nerves. It gives you the diagnosis here is that you can see discrete foci of enhancement in the optic radiations bilaterally. So the differential of a supracell mass is an optic glioma, which is in this case. The things that help you towards that diagnosis on these two images, inverted V shape and the enhancement in the optic radiations. In other words, on optic nerve tumors, the CT is best when you have an entirely intraorbital mass contrast from the intraorbital fat. If you want to assess the remainder of the optic tract, then fat suppressed post-contrast MR is the optimal method. MR also gives you better information about the supracellular relationships, can determine whether something arising from the optic nerves or from the pituitary gland, and it also obviously gives you the optic radiation involvement, which CT is identifying. In doubtful cases of a supracellular mass, well, it can be very difficult to determine where it's originating from, so cases MR spectroscopy can be useful. A juvenile polycytic astrocytoma, like all tumors, essentially has reduced NAA and elevated choline. Cranial and usually pituitary adenoma has no parenchymal markers either, but some elevated choline. So that can be somewhat helpful. And in this case, we have an optic. So we have a 2-year-old with no idea what. Okay. We have a non-contrast T1 weighted image and a T2 weighted extensive ventricular enlargement, a small amount of air related to a ventricular shunt, a large cauliflower-like mass arising from the lateral ventricle, some dark foci within it, which may represent either flow voids. And you can see here, I'll just point out dark little foci in the image here, which are helpful in making this diagnosis as well. The post-contrast image shows very intense. So this is clearly a choroid plexus tumor given the very extensive enhancement, given the cauliflower-like appearance. These are more common in children and are more ventricle. And when they do get them, they're usually in the fourth ventricle. The big differentiation is whether this is a carcinoma. There are some features on MR, which I'll go over in a moment. Essentially, the differentiation is histologic, because you can get some of features. Is that papillomas, such as this example, are lobulated lesions and frequently have foci of T2 hypointensity within them, and that is meant to be a particular feature of papillomas. They obviously enhance very intensely, and they may show some foci of calcification and blood on non-contrast CT. Papillomas are generally confined within the ventricular space, and it can show parenchymal invasion, and these are the ones that are difficult from carcinoma. Carcinomas are more generally heterogeneous. They typically have parenchymal invasion and set up an edematous parenchyma. They have large cysts and large foci of hemorrhage. And they look like dirty, aggressive tumors. So the brain parenchyma and the ventricular system, aggressive-looking tumors with a lot of hemorrhage. Differential diagnosis also includes primitive neuroectodermal tumor, ependymomas, and acycloid tumors. Papilloma, a particularly characteristic example of one. The 40-year-old female patient with intermittent paresthesias It was quite reasonably straightforward diagnosis of the bilateral ventricle, and we're just at one side of the corpus callosum, and you can see multiple foci of T2 hyperintensity paralleling the lateral ventricle. In an appearance typical of the dust fingers, seen periodontal sclerosis. This is again seen on the axial images here. The oval finger-like foci of T2 hyperintensity, which parallel the distribution of the periodontal. So images that you can look for from a callosal filling. On the sagittal FD, you can see serration of the inferior surface of the corpus callosum related to small little demyelinating foci within the corpus callosum. Infratentorial or cervical lesions, which may support this diagnosis. And obviously, if you have previous films, if they come and go, that's also supportive of MS. MS can not infrequently enhance the typical enhancement in an active plaque. And the characteristic feature of the enhancement in MS is that the ring of enhancement is incomplete. So this is a fairly classic example of multiple sclerosis with a sudden severe headache. So I had a which showed a hydrocephalus, little hypoattenuated Varices subarachnoid space here. So the question was whether there was a fracture with dural tear and small amount of subarachnoid air. And the patient had an MR which showed this hyperintense focus within the midline. And all these areas which are hypoattenuating CT are all very T1 weighted image. So this clearly limits the differential substantially with things that are bright on T1, essentially being fat, and melanin, contrast, and blood. Clearly it's not blood based on the CT, and it's bright on T1, and dark on non-contrast CT is fat. So the history of the recent herring here, so what we have is a midline dermoid or possibly lipoma, which is ruptured instead of the headache. So when you see these multiple hypoattenuating foci in the subarachnoid space, think of air, fat, and pantopaque, which used to be used for myelography a number of years ago. Fat obviously was less when you use fat saturation, and sometimes you may see the lipoma on CT because you see an eggshell-like fine peripheral calcification, although that's common. So this is a ruptured dermoid. Okay, so this is adults with essentially the same diagnosis, all presenting with seizures. A non-contrast T1 and a T2 weighted image. And you can see this subtle alteration of the lateral ventricle on the left side, which corresponds in a slightly more inferior image with these slightly iso-intense structures which indent the outer aspect of the ventricular surface. And these are another patient, this is a contrast-enhanced study, again shows a similar nodular indentation along the atrium of the right lateral ventricle. And again, these are just the non-contrast images showing again this alteration in the structure. Probably easier seen on the T2 weighted images here. This is an FSC image, and again you can see this nodular mass, which is iso-intense to gray. A small amount of hyperintensity within it, which is actually a small tract within from the lateral ventricle. So we've multiple cases with a nodular mass beside the ventricle, doesn't enhance and tracks grey matter on all seats. Diagnostic of heterotopia or collections of normal nerve cells in abnormal locations. They can be isolated or associated with other anomalies. Most isolated is subependymal nodular heterotopia that we have here, and most people will present with seizures. In those patients who have heterotopia associated with other anomalies, they may present with mental retardation or other more profound neurologic abnormalities, usually related to the other anomalies which are present. It's subdivided into subependymal, which is usually the sporadic type. There's a familial type as well, which is ependymal. Focal subcortical, like the last case we saw, and the other type, which is a band heterotopia, which produces the double cortex or stripe of grey matter suspended within the white matter. And this band heterotopia is more associated with chromosomal abnormalities and neurologic symptoms. Okay, so the critical things to look for on imaging are these smooth ovoid masses, which must track grey matter on all sequences. and must not enhance. They don't track grey matter on all sequences, the major ependymal hamartomas and tuberous sclerosis, which look very similar but are subtly different in signal to nature. So this is a subependymal nodular heterotopia. Okay, next case is a 60-year-old man who had altered mental status in the background layer and status of non-contrast T1 shows a subtle area of reduced signal within the central aspect of the pons. You can see here that there's no real change in the morphology of the pons itself. The flow void of the basilar artery is a normal location. There's a nice amount of CSF and to it. The FSC-weighted image shows to greater effect this very well-defined area of hyperintensity within the pons with sparing of the periphery. And again, just you can see the images. This sparing of the periphery and the absence of pontine enlargement is the key to the diagnosis here, which is the pontine myelitis, which is more usually termed now an osmotic demyelination, so that because the process can frequently outside the pons. So sometimes you may get a classic kind of trident shape, which does not show, but the classic, the pons is not enlarged and the periphery is spared. Osmotic demyelination may also involve the deep white matter and the internal and external capsules, and has also been reported in the cerebellum. If you see it in the pons, really the differential diagnosis is very limited. Brainstem biomas tend to expand the pons far more markedly and wrap themselves around the basilar artery, while significant small vessel ischemic change tends to be a little bit more diffuse and may not spare the periphery to the same extent. If you see it outside the pons in any of these other areas, the differential diagnosis is greater and would include acute disseminal myelitis, tumefactive MS, extensive ischemia, or depending on where exactly, it may mimic an encephalitis as well. So this is just CPR demyelination. 6-year-old history, because essentially the history would give it away. And this is a post-stress T1. In the left IAC, you can see an area of enhancement contained entirely within the internal auditory canal. So this patient probably presented with hearing loss. The coronal image just shows this to greater effect here, as you see it extending, approaching the cochlea. So the differential of internal auditory canal extension CP angle now is schwannoma, usually of the acoustic nerve. If you see it, if it involves the facial nerve, the patient more likely has neurofibromatosis, meningiomastosis, particularly breast carcinoma, and don't forget the great mimic of the is a jugular bulb, so just make sure you can trace this so-called tumor right down in the two I'm going to talk about in greater detail are schwannoma versus meningioma, because these are the two most favored. Schwannoma are a mass which is centered at the level of the internal auditory canal, extends into the IAC and expands it. You may also get widening of the porus acousticus, which is along the medial margin of the IAC. Schwannomas do not have a dural base, so they tend to be a large kind of mass sitting in the CP angle that, while they may abut the dura, don't crawl along the dura like an meningioma does. And they're classically described as an ice cream cone, where you have the tiny ice cream cone within the IAC and the enormous blob of ice cream CP angle. In contradistinction, features of the are the center of this mass is eccentric to the porus acousticus and eccentric to the internal auditory. While it may extend into the IAC, it should not expand the IAC. The critical thing is that the mass in the angle is based on the dura, and you may get a dural tail. The majority of tumors, as in the example here, that in the IAC, about 95% of those are going to be schwannomas, and a couple of percentage points are going to be meningiomas. Entirely intracanalicular meningiomas are rare, but again, metastasis should be within that differential diagnosis for the example that we saw here. So this, in this particular case, have a series. Okay, so 6-year-olds. with headaches and vomiting. So this child thought to have a gastroenteritis, but eventually got into his brain. We have a non-contrast and a post-contrast study. Now in the non-contrast, you can see the slightly hyper mass, which is situated within the central portion of the posterior fossa, calcification, and a CSF collection beside it, which could represent either a cyst or may represent a partially obstructed portion of the fourth ventricle. You can see here that they're starting to dilate, so there's hydrocephalus. The enhanced study shows diffuse enhancement of the mass. And on MR, this really just shows a slightly hypodense T1 mass and slightly high T2-weighted mass. And the sagittal post-contrast images are frequently the most useful in these situations. You can see this large mass, which appears to be centered within the fourth ventricle, and you can see a cleft trying to extend above it. And this, we think, is left ventricle. You can also see the degree of inferior consternation caused by this. So hyperdense mass with calcification appears to be centered within the left CSF around it. So big differential diagnoses in this case, inline posterior fossa masses in childhood, are medulloblastoma, ependymoma, teratoma, like an exophytic brainstem myoma growing into the fourth. These are less common. So you really have to try and differentiate between the medullo and an ependymoma. And this can be very difficult on any imaging. So you can favor one or the other. Ependymomas can calcify in 40% and foraminal extension, as it oozes out of Luschka, is a very useful feature when you see it, but you only see it in half of cases. So if you see it, you can favor ependymoma. If you don't see it, it doesn't really help you. Features that favor a medulla are, rather than expansion of the fourth, because medullas arise from the superior medullary velum and tend to crush the fourth ventricle inferiorly. While the extent of medullas will show calcification or hemorrhage, and while that's less than ependymomas, it's still a substantial percentage for each individual case. So calcification doesn't have to be foraminal extension, there are one or two case reports, but it's really not very common. The subarachnoid or left elimination, I would favor a medulloblastoma, since this is more common than in 30% of patients with medullary seeding affection. So if you want to play the statistics case, you know, it cleft around it. It has calcification. It seems to be compressing the fourth ventricle. So if you had to put your money on it, you'd probably know it. But unfortunately, it turned out to be a medulloblastoma. Don't be too hard. Give me some for why you think one run, but don't take out a second order center. Okay. 17-year-old increasingly severe headaches. Again, this is a non-contrast T1 image, and you see a slightly hypodense mass in this cerebellar peduncle with a large and intense structure around it, which has a vaguely CSF. The T2-weighted image doesn't help you an awful lot more. Again, it neural mass of T2 signal within the brain parenchyma. The enhanced images are no enhancement of all of this cyst-related. Again, the sagittal shows the part of the mass. Of interest, you can see the significant small cervix in the cervical cord. So when you see the cystic mass with a mural nodule, again, there's a limited differential under the age of 10 years. Hemangioblastoma, which is more commonly seen in older patients, and obviously unusual metastases can be as well. So the features that would favor hemangioblastoma, and you're kind of around 15 or 16. You're at that kind of where it could be and for any evidence of cellular lesion elpsis would suggest multiple hemangioblastomas in the patient with multiple shell in the first degree relatives, which is angiocysts, which are also associated with multiple index. On angiography, it's not common to be hemangioblastoma. Astrocytomas, as I said, interesting in angiography, the non-regional is significant. So this is the cystic cerebellum, even though the patient
Thompson is about ready to give you. Now, Dr. Thompson has reduced like 15, 20 hours worth of information into a couple. Okay, so you got a lot of information coming. He's going to boil it down to its essence. Okay. I did have one complaint that was a little bit warm in here. You know, you can just. So I told the guys maybe they're going to have to take off their shirts or something like that if it feels too warm. Okay, so we're going to continue on here. It's with great pleasure I introduce Dr. Bill Thompson. Some of you may have seen him at the AFIP, Esophagus, Stomach, and Duodenum.
Thank you, Linda. I got out here fairly early, and I realized that for some reason the small bowel and the colon did not make it into the syllabus. What we'll do this morning in the first hour or so is talk about plain films, esophagus, stomach, and duodenum. And I really like plain films as an old radiologist, and I will tell you that on the boards you're likely in the abdominal section to see a plain film or two. So we'll talk about plain films and we'll go through esophagus, stomach, and duodenum together. This slide is probably the most important slide that I show you this morning. And that is that you all need to have an approach to the boards. It's very simple. I think you ought to, just like a daily consultant, and you ought to consider the examiner an internist or private practitioner who has a series of films, a study, wants to know what's on the study, wants to know what the cause of the problem might be, and wants to know what does he do with the information in terms of recommendations. So very simply, what you see, and I also think it's very important to tell the examiner what kind of examination it is. A plain film, an esophagus, a contrast-enhanced CT with the mouth, oral, etc. Describe the findings, and quite frankly, I even say how many images I'm looking at. Describe the findings, provide a differential diagnosis, and then consider what you might do next for the patient. And I think the biggest error that I've seen over the years is the radiology residents, all they can think of is another radiology test, another x-ray test. And it may be surgery, it may be endoscopy. So practically, what are you going to do to solve this patient's problem and help you get to the diagnosis, a percutaneous biopsy, etc. And so just act like a daily consultant in your daily routine work, and I think you'll be fine. I would also tell you that we are not supposed to be asking a lot of factual material on the oral exam. It's basically supposed to be a management seminar in a sense, so think of it that way. And the one thing, too, I think is very important, don't try to think what the examiner wants, because you'll fake yourself out. Basically, just describe what you see, differential diagnosis, and then what we do next. And remember, what we do next may not be an imaging procedure. So let's talk about plain films. Again, an approach. We'll talk a little. I'll go through an approach as we go through the cases. Talk about gas, calcifications, masses in terms of fluid and artifacts. Now, I don't mention anything about the technique unless the technique does not include the diaphragms or is too light or too dark. There'll be a problem on the boards. I think symmetry in terms of recognizing that there may be an asymmetrical gas collection is important, and we have solid organs, lung bases, and bones all part of the film. Simple concept, gas. Too much, too little, wrong place. What else can we see? Calcifications. And we also can see masses on plain films, but by the time it's a mass on the plain film, whether it be a big liver, big spleen, a big retroperitoneal mass, etc., that can be felt clinically and is not really a problem for us. But I still think it's important to describe them. So we can have too much gas in the stomach, gastric. We can have too much gas in the duodenum, and without a proximal small bowel obstruction, that usually means pancreatitis. And then obviously we deal with ileocecal obstruction in our daily routine, probably the most common thing we see in terms of abnormalities. So here we have somebody with a great big distended stomach. It turned out this patient was diabetic. Could this be a gastric outlet obstruction? Sure, okay. And yet this patient really did not have gastric outlet obstruction, except it looks like that. Here's a beautiful example of what I call a duodenal ileus in a patient with pancreatitis. I don't think anybody's going to have any trouble with this one. It looks like the NB peacock sign. And basically what we're seeing here is small bowel dilated out of proportion to large bowel, and this has to be a small bowel obstruction. Now here's a case where we're not sure quite what's going on, and a simple thing to do, it looks like there's too much gas everywhere, particularly in the colon, and a very simple thing to do is get a prone film and basically prove that this is just an ileus. So a prone film can be very helpful by basically letting gas get all the way down to the anal verge marked there by the yellow arrow. This is a classic example, something we see almost on a weekly basis. Dilated transverse colon with thickened ulcerations. This is classic, not pathognomonic, but classic for pseudomembranous thickening in the right colon as well. Could this be any type of colitis? Yes. But in our hospital setting, the most likely thing is pseudomembranous colitis. And if I'm an examiner and ask you what would you do next, what you ought to do is call a clinician up and find out is this patient on antibiotics, and you basically have your diagnosis. Now they have to prove that, but it's a pretty straightforward diagnosis off the plain film. So So we can have two little gas, it can be ascites or organomegaly, but the most important thing is, in the presence of obstruction, two little gas usually means a closed loop obstruction or a long-standing obstruction. Here's basically two little gas and one single air fluid level right there, and that was significant. This patient lady had 3 or 4 feet of dead bowel due to a closed loop obstruction. So seeing two little gas in the absence, in the presence of obstructive signs and symptoms is very, very significant, and I get very concerned about it. Here's a patient, I'm not showing you the plain film, but this classic string of beads sign, again, that tells you that there's lots of fluid in the bowel. And that's something we shouldn't see in small bowel obstruction, because most of the time we see too much gas. So seeing the string of beads, a paucity of gas in the abdomen suggests a closed loop obstruction or a more severe obstruction. And why do we see that? This is a classic string of beads. Here's a CT scan showing you marked location of a small bowel. This patient had a closed loop obstruction due to an internal hernia, and notice the little teeny tiny gas bubbles trapped up there in the non-dependent portion of the abdomen. Now, we can have gas in the wrong place. Over the liver, outside the bowel, localized portal venous versus biliary. Nobody's going to have any trouble recognizing that gas bubble right there. That tells you this patient has pneumoperitoneum. Very, very important point. Look at the right upper quadrant on every single film. The reason is we shouldn't see any air there at all. This is a little bit more subtle. Here's air in the right upper quadrant, and that's in air Morrison's pouch, and this patient had an intra-abdominal abscess. So the subtle little sliver of gas, a tiny little amount of air, may be the telltale sign it has peritonitis or perforation. Now, you probably won't remember much about this plain film talk, but I think all of you are going to remember this, because look at these guys. And this is the classic Liebhofen sign of free air, and those are slips of the hemidiaphragm outlined by air. And you'll remember that more than anything else. Another case where, again, asymmetric gas collection here in the left upper quadrant. We have a soft tissue mass inside a very peculiar circular gas collection. That turned out to be an intra-abdominal abscess that contains small bowel within it. This patient had a perforation from a mesenteric implant, or I should say an implant on the bowel wall from ovarian cancer, developed a perforation and abscess, and those are fluid-filled bowels surrounded by air. Again, an asymmetrical gas collection makes no sense. You may want to do a CT, you may want to do something, but you prove that that's abnormal, and CT is probably the way I'd go here. Now, very peculiar asymmetric gas collection. It's in the wrong place. And basically, that was an abscess. And we also have another kind of abscess, and that's the homogeneous gas collection that we see here. And both of these patients had perforations with abscess. So these asymmetrical gas collections can be the telltale sign that the patient has some type of intra-abdominal abscess. And depending upon the clinical situation, this patient's either going to go to surgery or have a CT. Nowadays, you know, we drain an awful lot of abscesses percutaneously. Now here's marked pneumatosis and pneumoperitoneum. And this is a balanced pneumoperitoneum with pneumatosis in a patient with scleroderma. Clinically, this patient was not that sick, and yet there was massive pneumatosis here. And so, putting the two together, you know this patient can't have dead bowel, or she'd be on death's door. And we know there are a few conditions that basically can give us sustained air in the bowel wall, as well as pneumoperitoneum, and it's not a surgical emergency. So obviously, knowing how sick this patient is really important. I don't think any of us are going to have too much trouble recognizing that there's a tube full of air in the central portion of the liver, and that's going to be biliary air. We know that biliary air should be more central, and notice that it looks like the common bile duct, versus this structure, which we see marked by the black arrows. That's the main portal vein, but notice there's a spiderweb appearance out in the liver. That's portal venous gas. That spider web out in the liver, I call it a spider web, we see air way out in the periphery of the liver. That basically tells you that there's portal venous air. You will never see biliary radicals out that far in the liver containing air. Very important. We know the most common cause of biliary air is something we did to the patient. Most common cause of portal venous gas is dead bowel. So it's really important to differentiate the two. I'm not sure how well this projects, but again, if you look over the liver, we see this kind of racemose or spiderweb appearance. You know that's portal venous air. We look very carefully. There's pneumatosis here. We have a distended cecum, and this turns out to be a cecal volvulus with portal venous gas, pneumatosis, as well as portal venous air. You can see the blue arrow marking the portal venous and the yellow arrow marking the very subtle pneumatosis in the colon. Very, very important. Now we can have wrong place, basically intraperitoneal free air, localized air outside the GI tract in an abscess. It also can be in the solid organs as well as in the peritoneal cavity. And then retroperitoneal air usually means perforation as well as abscess. Now I'm not going to spend time talking the various signs of this disorder with one caveat, and that is number 2. In up to 60 to 70% of patients on a supine or a prone film, we will see some evidence of pneumatosis in the right upper quadrant. I don't mean pneumoperitoneum in the right upper quadrant. So look very, very carefully at that. Here's a classic Wiggler sign. I personally would have a lot of difficulty if I showed this on the boards and someone didn't recognize this, because this is clearly something we have to recognize. The clinicians will never recognize this. Air on both sides of the bowel wall. Key point is, you have to identify this someplace where there aren't adjacent loops, like the right upper quadrant, the pelvis, etc. Because if you look over on it, you can see what looks like a Wiggler sign, but there are adjacent loops of bowel there, and so you can't call it. Clear call in the right upper quadrant. Basically, I mentioned air in the right upper quadrant. Here's a diagram of what we see. There's another gas bubble. We should not miss this at all. There should not be any radiolucency in the right upper quadrant. And I will tell you, occasionally we'll have skin folds and things that can be a problem for us. And the key thing is to recognize that and say, okay, we have radiolucency in the right upper quadrant. I'm not sure what it means. Let's give it a problem to prove that it is or isn't free air. We can have air around the free edge of the liver. Two very subtle cases. Obviously, that gas collection makes no sense. And if you look below that, there's also a very subtle Wiggler sign. And you look at the other side, there's this little linear strip of air, perforations and intra-abdominal abscess. And the only findings on the plain film were these subtle collections of air in the right upper quadrant. So really important to look there. Now here's a case that doesn't make any sense. And one of the things I try to teach our residents, when you see air that doesn't make any sense, it's not in bowel, it's not in the intraperitoneal cavity, it has to be retroperitoneal. You look in the right upper quadrant, there's a whole bunch of gas bubbles that don't look like this any place else in the abdomen. And if you look in the right lower quadrant, there's sort of this V-shaped linear gas collection. It doesn't make any sense. That has to be retroperitoneal air. It turned out this patient presented with a sudden onset of upper abdominal pain, and this was due to a perforated posterior duodenal in the retroperitoneum. So a diagnosis of retroperitoneal abscess with perforation, probably from the duodenum, could be made for this plain film. Now, if you're down what this is, obviously the next thing to do is a CT scan. But if this patient presents with a classic history, this patient can go straight to surgery to have ulcer overfill. And that basically this guy had a study and a contrast study because he was not that sick. But if somebody's acutely ill, you see these findings, to me that's enough to send the patient to surgery. Now calcification is something that's very important for us in the abdomen. Why? Because we can see it. The abdomen film may not be very good for lots of things, but it's very good for detecting calcification. And I basically like to use this scheme of calcification in terms of classification that comes from Steve Baker. And you see the four various types there. What do we mean? Well, conduit wall, here we basically have three conduits, one man-made and two part of the patient. We see vas deferens calcification there, conduit wall. We see blood vessels there, and of course this patient has a double J stent implant. We know this patient, most likely in this country, has type 1 diabetes. If he was from a foreign country, he might have schistosomiasis or tuberculosis producing that vas deferens calcification. But when we see that, we can say this patient has diabetes type 1. Now, this is an unusual case. We look and see this curvilinear calcification that doesn't make a lot of sense. And there is an overlap in the scheme I just gave you between aneurysms and cysts. This looks like an aneurysm. What's unusual about it is it's very saccular. But this was a saccular aortic aneurysm. Here we see a curvilinear calcification in the right lower quadrant on CT scan to be a porcelain gallbladder. Again, cystic wall type calcification. Mesenteric cyst could be anywhere in the abdomen. Again, a cystic type of calcification. And then we have two different types of fibroids. Basically a solid calcification and a cystic calcification, both due to fibroids. Most of the time we see fibroid calcification is solid, like here on your left, but we can see a cystic variation as well. Lymph nodes can calcify, a solid calcification. And then we have these laminar calcifications, or so-called concretions. And what this tells you is these are marking something that basically is keeping the calcification. And this indicates stasis. Where do we see stasis? In the urinary system, in the biliary system, and then we'll see also enteroliths give you calcification, can give you this kind of calcification as well. Notice it's laminated. We call these concretions. And this basically was in an ileal loop. Now, we can also classify calcifications in a variety of other ways. And obviously, the smaller the compartment that we can put the calcification in, the more likely we are to make a diagnosis. Now, in terms of masses, I already mentioned that we can have a lot of things that look like masses. By the time we see masses in solid organs, we see cysts, we see tumors, we know the patient has that clinically. And the same thing about ascites. Here's somebody with increased density in the abdomen. Notice that there are no normal soft tissue planes above. The spleen's a little bit prominent, but more importantly, look here. Here is paravesical fat in the pelvis. Everything above that can't be bladder. And if you look and see it's filling the pelvic recesses, this is indicative of ascites. And this patient actually had a ruptured spleen, and that was blood. Everything below that has to be bladder. Okay, and so that's a very important finding for us in terms of making the diagnosis of ascites. And obviously in trauma, it's a good marker for blood. Let's now turn to esophagus. I don't know how you all are taught in your institution, but I think it's important every time we look at a disease involving the hollow organs of the GI tract that we ask ourselves, is this a mucosal interluminal process? Is this a submucosal process in the wall? Or is this a serosal extrinsic process? And the reason is we can narrow our differential significantly if we can compartmentalize like this. And in doing that, I would say that 85–90% of the time we can tell that the lesion is in one of these three places. There's definite overlap. We'll talk about that. And we can have benign causes and malignant causes producing the abnormalities in the three locations. Remember that in the esophagus, there isn't a serosa, but basically we're talking about something that's extrinsic. Now, I'll just very briefly mention normal anatomy. We'll talk about filling defects, ulcerations, causes of those, diverticular strictures, and motility disorder. The esophagus, if we can catch it in good double contrast technique, should look like this. It looks like a featureless mucosa. Unfortunately, as you know, this is about a 50-50 proposition. It depends upon how well the patient can swallow, how much contrast they can swallow, and how well air refluxes back up the esophagus while they're swallowing. We talk about filling defects. We'll just go through these very simply. Obviously, the most common thing are tumors, and quite frankly, mucosal masses, inflammatory lesions, all these things are much less common than malignancies. But this is a differential diagnosis of things that we can see as benign masses. This is a very unusual case. This is squamous papillomatosis, and I might show this case on the boards to get an understanding of what you all have in terms of differences for little nodules like this in the esophagus. And so this is a differential diagnosis of multiple small nodules in the esophagus, and there are a variety of things that can do this. Here's a classic inflammatory pseudopolyp of GERD in the G junction. This looks irregular enough, though, and many of these look so irregular, that you basically need to endoscope the patient to make absolutely certain that they don't have a malignancy there. Now, we can have, obviously, the most common thing we're going to see is squamous cell adenocarcinoma. Basically, here are three different types of cancer. The most important one is C. Remember, as one of my former colleagues in Minnesota mentioned to me, it told me many years, the esophagus is a cancer-producing organ. So every single time you see any abnormality, you have to ask yourself, could this be cancer? You may discount it, but some of the strictures produced by cancer can look very, very benign, as we see in C. Here's a very subtle tumor in the esophagus. Just a little bit of mucosal irregularity, tiny squamous cell cancer. These lesions are going to be a great big polypoid mass on your left and a large signal area of ulceration on your right. Pretty straightforward. Here's an isolated ulceration in the middle third of the esophagus, again, due to cancer. Now here's the lesion. The lesion on your left can be problematic. This is a so-called pseudoachalasia, where we have diffuse infiltration of the wall of the esophagus, and it can look very similar to achalasia. Key thing here is to get this patient scoped. With achalasia, the scope is going to drop right through into the stomach. With cancer, obviously, you're going to run into a dead end of stricture, okay? And metastatic disease is also in this differential. And on your right, you see somebody with a big distal cancer at the GD junction. Now, we can have great big lesions in the esophagus that produce what look like submucosal masses. And here's the list of these. And these are a little bit different diagnosis because these tend to be big lesions without a lot of ulceration. Certainly, primary abnormal and squamous cell carcinoma fits in this differential. But most of these lesions are 3 to 5 centimeters in size. And so this is a different type of differential than straightforward adeno or squamous cell cancer because those are mucosal lesions. These are submucosal lesions, and most of these do not produce significant ulceration. Here's a great big lumpy, bumpy, what Brenda Nelson refers to as a soft tumor. It's a great big lymphoma. Here are two cases, again, relatively soft-looking lesions. They look submucosal, and these are spindle cell tumors. Now this is a very unusual case. Again, somebody that you're going to be worried about achalasia, but this is pseudoachalasia due to breast cancer. So every time you see a lesion that looks malignant, you want to always mention primary tumor, lymphoma, and metastatic disease in the same sentence. What I see the residents doing a lot of is they'll jump back and forth between benign and malignant conditions. And if you don't mention those three in the same sentence, you'll usually leave one of the three out, and it usually ends up what it turns out to be. So So these big submucosal masses, in the esophagus we know benign, the leiomyoma is the most common. And remember that the differential diagnosis of submucosal masses is basically very simple. It's omas and everything that lives there. And here you can see a number of things on this list that can basically look benign, even though the spindle cell tumors and metastasis and lymphoma obviously are malignant. Leiomyoma, most of these are discovered incidentally. They basically indent the wall but do not displace the entire axis of the stomach like an extrinsic lesion can do. And many of these are discovered incidentally. Remember that in the esophagus, the leiomyomas, elsewhere in the GI tract, they're gastrointestinal stromal tumors. And nobody understands that. 75–80% of all submucosal masses we see like this are leiomyomas in the esophagus. In the GI tract, in the rest of the GI tract, it's exactly the opposite. They're all cysts, and nobody knows why. There's a great big huge filling defect. This is a giant fibrovascular polyp, and I sort of apologize for this slide, but this points out the fact that people can aspirate these giant polyps and die. I hate that it looks like the Pope. Sorry about that, but it's very, very peculiar. GI radiologists are a very peculiar line. We have all sorts of unknowns. I like to show this as an unknown in my esophagus talk just to keep people on their toes. Obviously, we can have uphill and downhill varices. The most common thing, basically, are the uphill varices, and quite frankly, we just don't image these patients anymore. We do on CT, but we rarely do a GI study to evaluate for varices. Here's a classic appearance of varices, multiple worms in the wall of the esophagus. Notice that we see these best with the esophagus partially distended, but I quite frankly can't remember in the last year diagnosing a case of varices in a patient. We used to do this on a daily basis. These patients are either endoscoped or have nothing done to them at all. Now, there's a variety of things that can involve the esophagus extrinsically that are listed here. Cervical osteoitis we see every single day. Obviously, lymphadenopathy from tumors, vascular impressions, etc. Here's basically an indentation in the posterior wall of the esophagus running from the port to the right shoulder. And on CT scan, we can see this going behind the aortic arch. And this is a apparent right subclavian artery with a left aortic arch. It's important to know that, because obviously this patient doesn't need any surgery or any therapy. A great big mass here displacing the esophagus. We see it on double contrast. It looks extrinsic. This is actually a wall lesion, and this turns out to be a duplication cyst. One of the things I will tell you when trying to differentiate mucosal from submucosal and submucosal from serosal is that we can have overlap. It can be difficult at times to differentiate. But differential diagnosis is an extrinsic mass as well as wall lesion here, and this turned out to be a duplication cyst. And we can have foreign bodies. Most of the time when we have food impacted, it's above a stricture. We also can have a variety of other things that patients swallow, as you see listed there. Here's somebody with a meat impaction, and basically has stricture at the GD junction producing this meat impaction. Now, in terms of esophageal ulceration, the most common thing, obviously, is Varices esophagus, but there are a variety of things listed here that can also produce ulceration. And I emphasize, with the asterisk there, Crohn's disease. Very uncommon to see Crohn's disease in the esophagus, but if you see little aphoid ulcers, well, the most likely cause is going to be reflux. Remember that Crohn's disease basically can occur in the upper GI tract, and the key thing to do next, if you see that, is just keep the barium going and finish the examination with a small bowel polyp fluid to see if the ileum is abnormal, because most of the time, when there's disease in the proximal GI tract and Crohn's disease, the ileum is also abnormal. Marked irregularity and distortion of the esophagus, classic reflux. I will tell you, though, that we do not do a very good job on our variant studies picking up subtle esophagitis. It's just something that's difficult for us to diagnose. Hiatus hernia, and then obviously marked distortion and irregularity. And I would also tell you that anytime I see any evidence of esophagitis, I suggest the possibility of Varices, recognizing that I may be overcalling it, but I do think it's important that these patients get scoped to rule out Varices. As we know, it's a very, very common disease. Multiple little teeny aphoid ulcers here. There's a differential for this, obviously, which I've given you, and this turned out to be due to reflux. Could this be herpes? Absolutely. Could this be Crohn's disease? Absolutely. Could this be Bechet syndrome? Yes. It could even be CMV, even though CMV, as I mentioned, tends to give us bigger ulcers. Now, Barrett's esophagus, as you know, is a metaplasia. The etiology is reflux. The incidence can be up to 10% in patients with GERD, and the problem with it is there's an increased risk of cancer. It can look very peculiar like this. Here's an area of metaplasia, the metaesophagus. Picture in the mid-esophagus, and whenever we see this, we have to say, gee, this could be varices. Let's give this patient an endoscope right away. Another case of varices. Again, mid-esophageal stricture, varices has to be high differential. Now, we can also see ulceration with infection as listed here, as well as some of the other things at the bottom of the list. Now, it turns out that usually doesn't give us ulceration, but gives us plaques, unless we get horrible shaggy esophagus where we have severe ulceration because of tremendous bacterial overgrowth, or I should say overgrowth of the infection. But most of the time, we see these little teeny tiny plaques. And the most common thing to give us little teeny tiny plaques like this is basically Candida. Again, we're not seeing many of these patients anymore in radiology, primarily because I think they're being diagnosed on the ward and maybe even being endoscoped. You see the very long, flat ulceration here, characteristic of CMV as well as HIV esophagitis. Have no idea exactly why this occurs, but these long, flat ulcers like this are very characteristic, particularly of CMV. Multiple ulcers here in the mid-esophagus in a patient with Crohn's disease, but this certainly could be herpes or CMV and even severe reflux. Now, esophageal diverticuli, I think you're all aware of this. There are two types: traction, basically most common, middle third of the esophagus due to tuberculous lymph nodes, and then three different types of pulsion diverticuli. There are a couple of other minor pulsion diverticuli that occur in the middle esophagus, but the most common things are Zinkers, Killian-Jameson, and a pepperphrenic. Remember, though, that a Zinker's diverticulum is not an esophageal. It's actually a hypopharyngeal diverticulum because it occurs above the cricopharyngeus. But Killian-Jameson is a true diverticulum of the esophagus. It occurs below the cricopharyngeus. The pepperphrenic is down by the hemidiaphragm. Classic Netter diagram, you can see this large Zinkers producing posterior indentation on the rest of the esophagus there, and you can see the cricopharyngeus. So this goes to the dehiscence of Killian. These are clinically significant, where the Killian-Jameson diverticuli are rarely clinically significant. These patients incidence of symptoms. Classic appearance on your AP and lateral film of variant swallow. Notice again that this is a hypopharyngeal or pharyngeal diverticulum. It's posterior. And many of these patients have significant symptoms: food, aspiration, etc. Contrast that with the Killian-Jameson, which is basically below the cricopharyngeus. The blue arrow is marking the position of the cricopharyngeus. The yellow arrow is marking the Killian-Jameson diverticulum. This is one of the larger Killian-Jameson diverticuli I've seen. These can be bilateral, but they rarely cause symptoms. And you should have no difficulty differentiating them from a Zinker's diverticulum because these are lateral, where the Zinkers are posterior. Probably related to some kind of neuromuscular dysfunction problem at the GE junction. Anatomical weak spot down here, and these can become large enough, trap food, bleed, ulcerate, perforate, etc., and occasionally need surgery. And then here's a classic traction diverticulum from tuberculosis, and many times we don't even know that the patient had TB when we see these until we find out that they basically had a PPD that converted, or they had TB diagnosed in the past. Now, intramural pseudodiverticulosis basically are inflamed mucosal glands. Most common thing I've seen them in is reflux. They can also be seen in infection, and they tend to occur in areas where there's narrowing of strictures. And here's a classic example of intramural pseudodiverticuli. These should not be confused for ulcers. You notice they have little teeny narrow necks and rather broad-based diverticuli in terms of their bulbous end. And they're very, very characteristic, as I said, in reflux, particularly around areas of narrowing, and you can see them in infection as well. Esophageal strictures. I basically call everything that narrows the esophagus stricture, but basically these two things, the Schottsky's ring and the esophageal webs, are really 1 to 2 millimeters thick, and so we're probably stretching the overall definition. Remember that the lower esophageal ring is not called the Schottsky's ring until it's 13 millimeters or less. That's the 13 millimeter tablet came from. Now, in a patient like this that has about a 5 or 6 millimeter Schottsky's ring, I'm not going to give this a pill because it's not there. So why would you want to do the patient if you don't have to? And sometimes the pills can produce significant symptoms. Here's esophageal web, and it's hard sometimes to tell exactly where this is. This also could be a pharyngeal web. But you notice the little teeny tiny air bubble just beneath it is kind of a marker. These are clinically significant, and by the time the patient's endoscope, basically they're treated because the endoscope will basically break these webs up. And unless these are circumferential, they rarely cause symptoms. Now we can have a variety of things that produce strictures, as listed here. Obviously, the most common thing is going to be esophagitis. The second most common are going to be malignant tumors. There's a variety of other things in the differential. For whatever reason, nasogastric tube tends to produce long viscosity of many things to narrow the esophagus. There's a severe stricture due to reflux. This is a severe stricture due to lye ingestion. Those are the long lower third stricture. Lye ingestion can also give you short segmental strictures, sites in the esophagus, as well as producing long strictures. Here's a long stricture due to a nasogastric tube. Interesting thing about this is that there's no correlation between the time the patient has the tube and developing a stricture. Some patients will have NG tubes in for months and have no stricture formation at all. Other people have them for days or weeks and basically subsequently get a stricture like this. So you see a long, smooth stricture like this, you might ask yourself, gee, could this be cancer? But it just doesn't look like it. It looks too benign. Here's basically a radiation therapy stricture in the upper third of the esophagus. Usually this is not a problem because we know the patients had lymphoma, lung cancer, something like that, and we can make it specific. This is fundoplication. We basically are seeing a lot of these patients GERD for whatever reason, at least in our hospital, is very, very common, and we probably see 2 or 3 cases like this a week. Now, in terms of motility disorder, I can't remember exactly which chapter it is, but I think it's the very first chapter in the textbook. It's about 15 pages long, and that's every single thing you need to know about motility. It takes you about 15 minutes to read it. And here's a differential diagnosis of primary motility disorders. Obviously, we see achalasia. Diffuse esophageal spasm is actually fairly rare, but the presbyopia esophagus, now probably really called non-specific esophageal motility disorder, is fairly common. To make the diagnosis of diffuse esophageal spasm, at least for me anyway, that patient, when their esophagus starts contracting, I want to hear that they have a reproduction of their pain. Classic achalasia, not much of a problem, but remember, we need to be asking ourselves, gee, could this be a cancer doing this? The fact that the esophagus is as dilated as it is, and most of these patients have symptoms for many years, kind of helps you lead your diagnosis towards achalasia and not cancer. I would also point out that occasionally I have patients that have very early achalasia where it can be very difficult to make the diagnosis, even using manometry, and it may take a year or two for the patient to have full-blown florid symptoms before the diagnosis can be made. The classic corkscrew esophagus, and without significant pain, this is presbyopia esophagus or diffuse esophageal motility disorder, which means we don't know what the heck this is. Some of these patients will present with symptoms and some won't. Tertiary contractions by themselves are not really significant. However, these patients usually have altered primary and secondary peristalsis, and this is very common in our older population. Now, there are other things that can produce esophageal motility disorders, as listed here, and many of these things are systemic diseases. And even severe reflux can produce severe motility disorder, basically due to the inflammation of the esophagus. Here's somebody with a lower esophageal stricture, and this is pseudoachalasia due to carcinoma. And this patient had altered motility, but the real problem was down here at the GE junction. This is a classic example of scleroderma. Patients develop the lower 2/3 of their esophagus basically have no peristalsis. They have wide open reflux. They develop a stricture. As the stricture becomes worse, their esophagus even becomes more dilated. And end-stage scleroderma and end-stage achalasia can look very, very similar. And this patient has a stricture due to reflux, but this patient also had significant altered motility in the esophagus. To the stomach, again, mucosal, intestinal masses, submucosal wall lesions, serosal, extrinsic. A simple concept to try to help you narrow your differential. We'll talk about malignant tumors, benign tumors, and other things, as well as extrinsic things that might produce filling defects in the stomach. The most common thing, obviously, are going to be malignant lesions, as listed here. And notice that I have just under malignant and also have leiomyosarcoma there. Actually, you can see leiomyosarcomas in the stomach, small bowel, and colon, but they're very, very rare. Most of the time, these are going to be just, here's a polypoid lesion on your left and a circumferential antral lesion. Both of these are significant ulceration, and both of these are gastric cancers. Not a real problem here. What's in the differential? Well, you have to consider lymphoma. You have to consider mets. But I wouldn't think of GIST or metastatic disease or other things like that, significant metastatic disease or other things like that, because basically these look like primary mucosal lesions, lesions that are destroying the mucosa. Therefore, the most likely diagnosis is adenocarcinoma. Great big, lumpy, bumpy holes. The yellow arrow there on the left of the area is pointing at an ulcer. The most likely diagnosis here is I don't like it for metastasis because it's so infiltrated. And then here's somebody with diffuse lymphoma involving the entire stomach. Obviously, differential includes benign things that can give you great big holes as well. Both these patients had lymphoma. Very peculiar looking irregular lesion. Hard to tell exactly whether this is mucosal or submucosal. Not very well seen on this one particular image, but the very smooth, lumpy, bumpy margin makes me think that this might be a submucosal mass, and this turned out to be metastatic melanoma. Unusual, most metastatic melanoma in the stomach gives you multiple bullseyes, as we see here, and disease to the stomach. Unless it's direct invasion from pancreas or something outside, if it's hematogenous, we usually see multiple metastases. And the most common thing to do this is metastatic melanoma. Now, we know that gastrointestinal stromal tumors can be very, very exophytic. They can have a mural, intramural component, interluminal component, but very characteristically, these just face like the GI tract. And they can have 80-90% of their outside the GI tract. In fact, it can be very difficult to tell what organ they're coming from. You just have to know that GIST can do this. Recognizing that these in the past were all called leiomyomas. They've been reclassified because of the tyrosine receptor binding capability they have here, and special immunochemical stains separate these from classic leiomyomas. Can you have a classic leiomyoma in the stomach? Yes. In the small bowel? Yes. But most of the time you see a submucosal mass like this, it's going to be a GIST. The other problem about these tumors is that we do not have real good criteria pathologically to differentiate benign versus malignant, and many pathologists think these are all pre-malignant. When a pathologist sees a tumor greater than 5 centimeters in size and more than 5 mitoses per 50 high-powered fields, he calls that a malignant GIST. You can obviously have benign tumors, including GIST, but leiomyomas rarely occur in the stomach or small bowel, and lipoma is the second most common submucosal mass, and then the rest of the omas, fibromas, neuromas, etc. The blue arrow, the blood that was being produced by the ulceration here in this submucosal tumor that had little teeny tiny central ulceration, and this was a GIST. Here's a patient that has an antral lesion, smooth wall, central ulceration. And your differential diagnosis is what I said. The most common thing is going to be GIST, but could this be a lipoma or some other kind of oma? Absolutely. Anytime a submucosal mass becomes 3 centimeters or larger, particularly in the stomach, it's very likely that you're going to see central ulceration like this. And this actually turned out to be a lipoma. Now, mucosal polyps, the most common thing we see in the stomach are inflammatory polyps, but we also can see adenomatous polyps, and they need to be evaluated and handled and removed and followed just like colonic polyps, because the literature suggests that these adenomatous polyps are pre-malignant just like in the colon. Here's a little teeny tiny polyp or lesion here in the antrum of the stomach, and this turned out to be adenomatous polyp, and it was removed. We can have other things in the stomach that basically can produce masses or pseudomasses as listed here. A bezoar in a patient, a young patient, a child, who basically wasn't digesting food and was swallowing all sorts of crazy things. Classic appearance of submucosal mass in the antrum or the duodenum. You see the duct right in the center of the submucosal mass. It's a very classic appearance of ectopic pancreas. The ectopic pancreas can present just like any submucosal mass and be larger than this. Now here's a case, and it's not very well projected here, but you can see multiple what look like worms in the fundus. So when you see this in the posterior medial aspect of the stomach, you have to ask yourself, could this be isolated gastric varices? And the reason is that the next test is not endoscopy. The next test is a CT scan for this patient. But isolated gastric varices is splenic vein thrombosis due to pancreatitis or pancreatic tumor. And CT can make the diagnosis of varices as well as what's causing the varices. The problem we have is that you can have a great big, looks like a mass here. And you see the yellow arrow pointing to what looks like a great big submucosal mass. And this basically is an isolated gastric varix to a patient with splenic vein thrombosis from pancreatitis. So we don't want our endoscopy friends going down and trying to take a biopsy of some blood vessel, no sense. So when you see a posterior fundal mass that looks like varices or a solitary mass like this, relatively solitary, think of varices and recommend a CT scan. Now, this disease basically, in terms of ulcers, is just disappearing off the radar screen. We don't see a case of a gastric ulcer once or twice a year. The reason is twofold. One is, I think, quite frankly, these patients are being treated before they ever get an ulcer, or they're being cured with H2 blood before they're ever scoped or evaluated radiographically. So this is a disease which you used to see every single day when I was a resident and a young faculty person that we rarely see at all now. Multiple erosions like this, obviously the most common thing is erosive gastritis, and you want to know, is this patient arthritic, are they taking tons of aspirin in the different lung disease, Behçet's, but the most common thing to do this is going erosive gastritis. Here's a ring-like structure filled with contrast profile, you see it there, and this is a classic benign gastric ulcer. How do we differentiate benign from malignant ulcers? To me, the most reliable thing is to see that the ulcer penetrates past the imaginary wall of the stomach. Hampton's line, as I think you know, is a radiolucent line at the base of the ulcer that basically says it's definitely benign. The problem is we don't see it very often. Smooth radiating folds, ulcer collar, massive, etc. I think those things are terribly helpful. I think whether the ulcer penetrates or doesn't is what really helps me the most. Now we have obviously ulcers in malignancies, and even just, but the classic ulcer that we see that can be confused for a is basically that sits maybe in a mass, maybe not in a mass, not that the ulcer projects into the lumen. The irregular folds, I find are terribly helpful. Here's a great big ulcer on the lesser curvature of the stomach. And you notice that it does not penetrate past the wall of the stomach. You have to call this malignant. Could this be benign? Yes, but you have to call this malignant. Here's another one. Again, an ulceration on the lesser curvature right before we reach the antrum. Notice that the entire ulcer is inside the lumen. Therefore, this has to be a benign ulcer. I'm sorry, a malignant ulcer. Which I'll prove otherwise. And I would say that, at least in the old days, when we were seeing both benign and malignant ulcers, that 95% of all the ulcers we saw were benign. That may be now because we're not seeing nearly the number of benign ulcers. But I still use the criteria. Penetration, I consider benign. No penetration, I consider malignant. Now, this is something that I find many residents are confused about. And you'll show a great big ulcer in the middle of the stomach, and because it collects contrast, they'll indicate that it's a gastric diverticulum. Be mindful that 99.9% of all gastric diverticuli only occur in the posterior fundus. They have no clinical significance. They can be mistaken for an ulcer or mass. Rarely there's an intramural form that can be mistaken in rectopic pancreas or an ulcer, usually in the distal antrum. But that's not really a problem. Here we see this a great big posterior diverticulum, and that's basically the only place they occur. They do not occur in the body of the stomach. They only occur in the posterior fundus. Why? I don't know. But you should not confuse any collection outside the fundus of the stomach, posterior fundus, for a diverticulum. Now, obviously, the most common thing to narrow the stomach is cancer. But remember, in the differential, we want to include lymphoma, particularly Hodgkin's disease, which does not involve the upper gastrointestinal tract or the gastrointestinal tract that often, but when it does, it tends to give us a desmoplastic. And lung and breast are two other types of lesions, metastatic lesions, that can give us a desmoplastic reaction, particularly in the antrum. Here's a classic carcinoma of the distal antrum. Contrast to this tumor, which basically is lymphoma, and notice that it's crossing the pylorus. The reason adenocarcinoma tends to respect the pylorus, lymphoma doesn't. And then here's a patient with metastatic breast cancer. Could that be a primary adenocarcinoma of the antrum? Absolutely. Could it be lymphoma? Not terribly common unless we're thinking about Hodgkin's disease. But we have to consider metastatic breast and particularly metastatic lung. Now, other things can give you listed here. Most of these are really unusual. Here's a person with atrophic gastritis, and basically just smooth narrowing distal stomach. Could this be caustic congestion? Sure, lots of other things like that. This basically looks relatively benign. I still want to be scoped to make sure I'm not missing a subtle linitis plastica. Here's a patient who had swallowed lye about 6 weeks, and you can see the arrow pointing out a markedly distorted antrum. In the absence of that history, though, you've got to be worried about linitis plastica here. Hodgkin's disease and metastatic disease. But usually this is not a problem because we have the history. Now we can have just thick folds. And again, we all know that there's a big overlap between what's a thick fold and what isn't. I tend to think of any fold in the distal autonomy or fundus. Obviously, neoplasms can enlarge the fold as conditions of varices. Here's a pediatric cancer, and all we really saw, not very good study. And we saw just irregular thickened folds here in the mid-body of the stomach, and so that's differential. I've already shown you this case of lymphoma, again, on pretty thickened folds. There is a central area of ulceration there in the middle. Gastritis can give us thickened folds, and a lot of things in your differential, and these are really pretty unusual, with the exception of gastritis. Like esophagitis, unless there are erosions, we do not do a great job diagnosing gastritis, particularly gastritis. Here's a focal area of thickened folds. You notice that it's just in one area of the stomach, and this turned out to be focal gastritis. If I saw that de novo and didn't know the answer, I'd be worried about lymphoma doing that. Carcinoma, like for a metastatic disease, but as I'll tell you, lymphoma can look like anything in the GI tract, so I tend to think about and include it in almost every single differential. Zollinger-Ellison syndrome, there's an ulcer marked by the yellow arrow, and notice there's tremendous hypersecretion here, and you know that this patient very likely has Zollinger. The problem is this appearance only occurs in about 1/3 of the ZE cases. This is an old slide, as you can tell, but there's incredible diffuse hole thickening, and this is menintriase. Certainly lymphoma's got to be in this differential, as well as some kind of horrible ingestion or some kind of horrible gastritis. Now we'll close here with the duodenum. We can have filling defects that basically are neoplastic, benign tumors as well as malignant tumors. The non-neoplastic basically are the prolapsed antimucosa, the flexural pseudotumor, heterotophic gastric mucosa, and hyperplasia are the big group. And also, lymphoid nodular hyperplasia tends to look very similar to heterotophic gastric mucosa, tiny little nodules. Here basically we know the duodenal bulb shouldn't have any abnormalities in the bulb at all. It should have a very, very smooth appearance. Here's the prolapsed gastric polyp at the base of the simple diagnosis to make fluoroscopically. Here we have the flexural pseudotumor, and this is basically where the inner aspect of the duodenal bulb, where we see the transition of the bulb. Occasionally we can have a very prominent fold pattern. If you just bend your knuckle and look at it like this, you can see exactly what I'm talking about. With your knuckle of your MP here basically being the pylorus and the apex of the bulb being where your knuckle bends here. The tumor is basically moving the patient in different projections, and notice that this is a unique problem for us because it tends to be right in the base of the glands hyperplasia, blue arrow pylorus, tumor glands. Most people think camels. Some people feel they may be associated with dyspepsia, peptic ulcers. Many times we'll see it in patients. They can be quite large enough to obstruct the bulb. A variety of things, filling defects, other things. Here's somebody with a great big duodenal hematoma, better shown by CT. Now, benign tumors are really are not all that common in the duodenum. Again, are more common than leiomyomas. We can see lipomas in the Here we have an adenoma bulb. Differential patient has a polyposis syndrome. There are other tumors that can occur in the usual place to see collapsing polyp in the antrum space of the bulb polyp. Here we have a pedicle moving or synovium. It turns out the luminal mass that we can make is lipoma based on true diagnosis. It's a very good way to make the diagnosis. Once we're in the distal symptomatic. Obviously, here in the lymphoma and the cancer duodenum is the ampullary carcinoma is something that's in a differential. And I put in sarcoma, that's pretty something just as well. Due to adenocarcinoma duodenum. The most common appearance, however, is a short angular constricting lesion. Here's somebody that we see an extrinsic mass. And basically, this turned out to be lymphoma involving the duodenum. A wall lesion, wall or serosa, but this turned out to be a lymphoma involving the duodenum. This is an extrinsic mass due to cancer invading the duodenum. We used to see tons of peptic ulcers in the duodenal bulb. It turns out that we don't see one a year, and that's because, again, I think this is a disease that's gone by the wayside because it's basically being treated. There's really no reason to scope somebody if we see an ulcer because they're almost 99.9% are benign. Obviously, a variety of other things can produce ulceration. Classic appearance, ulcer in the central portion of the bulb, radiating folds. This has a 100% chance of being benign. We may see just a deformed bulb like this. We're not even seeing these very often because we're just not x-raying. Again, a deformed bulb due to ulcer. A patient with a short segmental stricture. This patient has a post-bulbar ulcer. Looks fairly aggressive, and I think this is a case where I would have difficulty saying this is definitely benign. But be mindful that post-bulbar strictures due to peptic ulcer disease can have a very peculiar appearance. Obviously, we can have congenital narrowings, inflammatory lesions, again, malignant in terms of overall narrowing. We tend to see a fair amount of patients with SMA syndrome in our hospital, and it's a relative thing. They basically have compression of their duodenum by the superior mesenteric artery because they've lost a significant amount of weight. Congenital atresias, not very common, obviously. Annular pancreas, we see periodically, and then we can have a variety of other congenital anomalies that narrow the duodenum. Here's a classic annular pancreas, circumferential, smooth, benign lesion in the second portion of the duodenum. And then, obviously, there's well, including pancreatitis, Crohn's disease, as well as post-bulbar ulcers. The post-bulbar ulcers, as you see here, tend to be asymmetric. in terms of their stricture formation. And notice that there's a lateral incisura. These are very characteristic of post-bulbar ulcer. And in many cases, we won't even know historically that the patient actually had an ulcer in the second portion of the duodenum. Here's a classic ram-torn or pseudobilary one sign of Crohn's disease involving the stomach and duodenum. Remember that Crohn's disease can involve the duodenum. When it involves the stomach, it almost always involves the duodenum. And if you see this, what's the next thing to do? Keep the contrast going and evaluate the terminalium to make sure the patient does have Crohn's disease. This patient had severe pancreatitis with marked narrowing of the duodenum. Pancreatic cancer can also do this. We talked about, we mentioned pancreatic cancer here, duodenal cancers, etc., are all part of duodenal. The most characteristic appearance for a duodenal or small bowel malignancy, adenocarcinoma, is a short, constricting apple-core type lesion we see here. Lumpy bigness, the most likely thing is lymphoma, because yes, ulceration, this is lymphoma. We have edema from Peptic Ulcer thickening. The diagnosis of duodenitis has a lot of variation in the whole disease in the second portion of the duodenum. And any of these things basically can give us fold thickening. We tend not to do a lot of radiology in most of these diseases. I've had various studies. We tend to do more CT in most of these. Here's somebody with duodenal fold thickening and an ulcer, a little bit of hypersecretion, and this is a patient with Solomons or Ellison syndrome. Another patient with asymmetric stricturing. Notice the blue arrow marking the little cute articuli. Those are almost pathognomonic of Crohn's disease. So every time you see little pseudodiverticuli like that, which implies asymmetric involvement anywhere in the small bowel, is just a manifestation of Crohn's disease. And in this particular, the barium was followed when the patient had Crohn's disease in the terminal. So what I've tried to do in this first hour or so is talk about an approach. Remember, gas, too much, too little, not enough. Wrong place. Calcium, some kind of machine to understanding of where the calcification might be located so we can narrow our differential. Esophagus differential diagnosis of Esophagus, ulceration, diverticula, pulse. Remember that zinc are diverticuli and killing diverticula, killing Jameson or esophageal diverticuli. Differential for esophagitis strictures so that the esophagus is a cancer-producing organ, and so every time we see a stricture, we have to be worried about a malignancy. And then obviously we have motility disorders, and the single chapter in Gore being basically all you need to know about motility disorders. Same kind of differential for things like malignant conditions. Again, try to figure out is the disease mucosal, submucosal, serosal, and go through a differential of those. Sometimes you have to include a differential of both and submucosal because you can't differentiate one from the other. Same sort of thing in the filling defect, ulceration, narrowing, and fold thickening. Thank you all.